symptom, which is one of the commonest, headache is one of the commonest symptom that we all come across in day-to-day clinical practice. I will share with you just the practical tips on how to evaluate a patient with headache. I will share my screen at this point. Can you see now?
Okay,
no. This is a picture. If you see anyone sitting like this with headache, it is definitely a migraine. So when we talk about headache, migraine comes to our mind most often. And in fact, that is a commonest headache also. Coming to relevance of the topic, it is the most common symptom that we all come across in day-to-day practice. The patients who come to us are more often worried about the fear of brain tumors. Therefore, at the end of evaluation, you must not forget to tell them that there is nothing to worry. That reassurance is the most important while managing the patient. It's not enough you prescribe some medicines. And unfortunately, it is almost always over-investigated. Even with CT scans, MRI scans, it needs skill, courage, and compassion to avoid unnecessary investigations like CT, MRI, and even procedures. I had my own personal experience because I was suffering from migraine since childhood. And I will share with you what happened to that headache at the end. There are two types of headache. Primarily, the common headaches or the primary headaches, where headache and its associated features are the disorder themselves, and there is no serious underlying disorder. The common headaches or primary headaches. Then you have the serious headaches or secondary headaches, which are caused by obvious disorders. The primary headaches, as we all know, is primarily the most important is migraine. Then you have something similar to that called tension headache, and a very rare cluster headache. It is one of the rarest primary headaches. The discussion will be more on migraine only. The secondary headaches or the serious headaches are very important when a patient comes with a headache. We need to find out whether by chance this patient is having that serious headache. And therefore, it is very important that we are familiar with them. The most important one, which is often missed, is cerebral vein thrombosis, because they come with a headache alone, and it's often mistaken for migraine. Meningitis is another one, but they have other systemic symptoms very often. Or it could be the headache could be part of a systemic infection like typhoid fever, or they may have subarachnoid hemorrhage or intracerebral hemorrhage. Brain tumors obviously can come with a headache, or raised intracranial tension of any other cause, which sometimes is called as benign intracranial hypertension or pseudotumor. Sometimes it is following head injury. Cerebrovascular disorders like cerebral vein thrombosis, cerebral arterial thrombosis, AV malformation, temporal arteritis sometimes, not necessarily CVS, vascular disorders, including cerebral arterial thrombosis, AV malformations, and vasculitic disorders can come with headache sometimes. Another important cause is ankylosing glaucoma. The patient might come with severe headache. One of the most important secondary cause of headache is cerebral vein thrombosis, which is very often missed out because the presentations are atypical. It's also a cerebrovascular accident. Often it is sudden onset. Seizures are very commonly seen. Neurological deficits can occur, and very often they have features of raised intracranial tension. So if you are familiar with the clinical setting, features of raised intracranial tension, neurological deficit, and a proneness for developing cerebral vein thrombosis, it's not difficult to diagnose. So look for prothrombotic states. Whenever we suspect cerebral vein thrombosis based on the clinical features, look for prothrombotic states. One should be familiar with the Virchow's triad, the hypercoagulable state, stasis, and endothelial damage due to a variety of causes. Very often, some of these patients are obese. Most of the time in our setup, in Indian scenario, we may find patients with B12 folic acid deficiency, with hyperhomocystinemia, dehydration due to a variety of causes in the background, or they may have polycythemia of various causes, or rarely young females, it may be antiphospholipid antibody syndrome, or even some of the myeloproliferative disorders like essential thrombocythemia or thrombocytosis due to other causes, or polycythemia rubra vera. These can all be presenting with intractable headache, which is often mistaken for migraine, and very often they are cerebral thrombosis. But if you look for the features, it is not difficult to diagnose. Among the secondary headaches, another very important one is brain tumors or intracranial space occupying lesions. In the absence of space occupying lesions, some of them may come with all the features raised nuchal tension, and CT may not be showing anything. That is called as pseudotumor or benign intracranial hypertension. These you suspect when there is a recent onset diffuse bifrontal headache, which is steadily increasing, interferes with sleep, and after sleep, there is early morning headache. Because in migraine, the headache, sleep actually relieves headache. Here, the headache will become worse after sleep. Also, the headache can become worse after exertion and positional changes. Headache can occur on coughing, lifting weight. It might occur in posterior fossa mass, but in severe migraine also, they may have increase on in headache on coughing and lifting weight. It need not be specific for posterior fossa mass. Headache arising de novo in a patient with non-malignancy should arouse suspicion of metastasis. Cerebrovascular accident, the commonest cause is intracranial hemorrhage, especially subarachnoid hemorrhage and intracerebral hemorrhage. They have their own telltale clinical features and sudden onset. Sometimes a cerebral arterial thrombosis, besides cerebral vein thrombosis, can also come with severe headache, especially when they develop pre-ICT. And they all have intracranial hemorrhages have the striking characteristic is sudden onset severe headache, the worst ever headache. And on examination, you may find a stiff neck and neurological deficits may be there if in case it is a cerebral hemorrhage or cerebral vein thrombosis, cerebral embolism. As a part of systemic infections, especially bacillary dysentery or enteric fever, they come with severe headache sometimes. These are people with migraine proneness very often. They come first with a very severe intractable headache. We had seen patients getting even CT scan done for that headache because fever might not be coming. Fever may be coming later the next day. In enteric fever especially, headache may be the first symptom. Even in acute colitis, bacillary dysentery, headache can be the first symptom. Meningitis obviously has acute severe headache, stiff neck, but they have fever to differentiate it. But meningitis due to conditions like tuberculous meningitis may not have fever always. So one should be familiar with that also. They have raised nuchal tension and nausea and vomiting. If it's an acute pathogenic meningitis, they have photophobia and the pain can increase on eye movements. So the point I wanted to stress here is one should be familiar with all the secondary causes of headache and their clinical features and how to find out, how to arrive at a clinical diagnosis. Ankle closure glaucoma is one problem where the patient can have severe eye pain, headache, and nausea and vomiting. And if you carefully examine, the eye will be redness of eyes with fixed and moderately dilated pupil. So that will be obvious if you carefully examine, and one can look for raised ocular pressure by digital palpation or can get an ophthalmology opinion. Rarely, the severe headache may be due to malignant hypertension. Always look at the blood pressure in patients with a typical vascular headache, diffuse bifrontal headache, and papilledema. Very high blood pressure may be obvious. But some patients with intractable vascular headache, especially persistent unilateral headache, may be due to having an AV malformation or sometimes intracranial meningioma on that side. These are all the secondary headaches. And another secondary headache is post-head injury. After head injury, they may come with a diffuse headache with a dizziness, impaired memory, anxiety, and irritability. Another condition which can occur in the hospital setting or after hospitalization, maybe the patient would have undergone a lumbar puncture After 24 to 48 hours, the patient develops diffuse bifrontal headache. But if you are aware of it, just ask the patient what happens when lying down. The headache is promptly relieved on lying down. It is precipitated by sitting and standing, or even reclining position can relieve it, or abdominal compression can relieve it, or it can be worsened by head shaking. So this is easily elicited if you are aware of the temporal relation between lumbar puncture and headache. Temporal arteritis is a very important but rare cause for severe headache, but it's unilateral and localized headache, dull aching with superimposed episodic sharp pain. You may find scalp tenderness and along the artery, and it could be worse at night and on exposure to cold. Patient can have systemic symptoms like fever, muscle pain, weight loss, jaw claudication, and even sometimes even blindness. So other symptoms of vasculitis may be there. So these are all the common secondary headaches or serious headaches. While trying to differentiate between serious headaches and benign headache, the decision is based on studying the headache in each patient very carefully. We must be aware of the clinical features of all these causes for secondary headache. And also, we must be aware of what is common and what is rare in that particular clinical setting. The rarest presentation of a common disorder like migraine may be mimicking raised rectal tension. So that is one thing which we have to keep in mind. So the common causes we must be very carefully elicited or thinking of in each patient while looking at the causes, rather than thinking of the rare causes. Fortunately, life-threatening headache is relatively uncommon. Even in an emergency setup, in tertiary care setup, only 5% of patients are having very serious headaches. But vigilance is required in finding out these 5%, which needs prompt attention. Something about the mechanisms of headache generation. The major parts of the brain are insensitive to painful stimuli. But one particular structure which is situated in the dorsal raphe nucleus of the midbrain, it's possibly a source of headache generation because sensory stimuli to this area elicits a headache which looks like migraine. This is detected by electrode probing. Sensory stimuli from the head are conveyed to this particular part, that is a dorsal raphe nucleus, and these sensory stimuli may be the trigger for the headache. Through the trigeminal nerve, from structures above tentorium cerebellae and anterior and cerebellae, the anterior and middle cranial fossa, and from the first three cranial nerves for structures in the posterior fossa and inferior surface of the tentorium cerebellae. The sensory stimuli are carried to the dorsal raphe nucleus in the midbrain through trigeminal nerve and first three cranial nerves, and that could be the trigger for generation of headache. This is the dorsal raphe nucleus I was referring to. It is situated here, and through the trigeminal nerve and first three cranial nerves, the sensory stimuli can be due to various benign causes or serious causes. It might be reaching here, and that can trigger headache. So this is a mechanism that is suggested. Electrical stimulation of the midbrain in the region of the dorsal raphe has resulted in migraine-like headache. That's the awareness that we have. It is a possible site of headache generation, and benign problems or even serious problems both can stimulate these sensory neurons, and the stimuli can produce a vascular headache. The secondary headaches are also due to stimulation of the pain-sensitive structures, but they are due to structural changes with the direct stimulation of the pain-sensitive structures, which are the pain-sensitive structures of the head. The scalp and upper neurotica, the fibrous tissue in the scalp, blood vessels, falx cerebri, dural sinuses, and fifth cranial nerve in this, as I mentioned, for the supratentorial compartment, and the entire dura mater, and C1 to C3 for the infratentorial compartment. Whenever any of these areas are stimulated directly by any kind of structural stimulation, by inflammation, distension, or spasm of the blood vessels, the same sensory stimuli are carried to the dorsal raphe nucleus, and you get similar headache. But so headache, which is vascular in character, can be stimulated by benign stimulus or serious stimulus. Serious or secondary headaches are due to direct stimulation of these pain-sensitive structures, or the migraine-like headaches are due to benign stimulus. But whatever it is, there is stimulation of the dorsal raphe nucleus. So the main concern to be addressed when a patient comes with a headache is it a serious headache or is it a common headache? The common headaches, it's all about migraine and its triggers. That's one thing we need to keep in mind. So therefore, all practicing doctors should know everything about common migraine, the clinical presentations, not only common migraine, all kinds of migraine, serious, and we should also know what are the clinical presentations of serious headaches, because we need to differentiate them from migraine. So what is migraine? What are the types of migraine, and what precipitates or what triggers migraine should be known to all of us. As I go on, I will be discussing on that. But one thing we should very clearly know, all headaches are vascular. Otherwise, it is a facial pain. Or more precisely, all headaches are neurovascular, but always exclude neuralgic pains like trigeminal neuralgia. Neural stimulation by any mechanism is the primary event. The mechanism may be a structural damage to any of the pain-sensitive structures or benign stimuli. Finally, the dorsal raphe nucleus gets stimulated and you get a vascular headache. The stimulation of the dorsal nucleus or the pain-sensitive structures by any mechanism will initiate headache. And the sensations are often carried through the trigeminal system. But for the posterior fossa, it is through the first three cranial, the nerves. First three nerves, C1, C2, C3. Vascular events are the final event in headache generation. But one should also know that migraine people have a hyper-responsive vascularity. They respond inappropriately to some stimuli which other people can tolerate, like people having bronchial asthma, having hyper-irritable airways. In serious headaches, it is due to direct stimulation of the pain-sensitive structures, as I mentioned before. So therefore, migraine, in short, is recurrent idiopathic vascular headache. There is no structural disease, but the patient gets vascular headache. There are no structural problems otherwise. And the headache can be frontal, frontotemporal, unilateral. With aura, if there is an aura, we call it classical migraine. Without aura, you call it common migraine. And the common migraine can be unilateral or bilateral. Common migraine can be frontal, bifrontal. Without aura, you call it as a common migraine. Migraine proneness is a primary benign disorder of the brain. That's one thing we need to know. And it can run in families also. The activities for migraine or triggers for migraine are different at different times. Very often we find multiple triggers for a migraine attack. The activities for a migraine are trivial most often. Sometimes the triggers can be serious, which I will tell later, like hypoxia, carbon monoxide exposure, or even some intracranial problems. One very important thing to remember is migraine is still underdiagnosed. People do not fail to understand it as migraine. Aura without headache can occur in migraine-prone people. That means in migraine, you have a phase of vasospasm followed by vasodilatation. During that phase of vasospasm, they may come with ischemic deficits in the area which is affected. If it is in the occipital lobe, you might find visual hallucination. If it is in the middle cerebral artery, the patient might develop hemiparesis. Or if it is in children, sometimes rarely it can occur in the abdomen. If it is and they may come with abdominal migraine. It's a rare presentation. Or if it is in the brainstem, you may get vertebrobasilar insufficiency, which we call as Bickerstaff migraine. But the headache component may not be there when the patient comes with a neurological deficit. One need to rule out all the other causes for that presentation and find out that the patient is a person with a migraine and migraine proneness, and they recover promptly after some time. So the point which I was trying to tell all throughout was all headaches are neurovascular. How do you identify a vascular headache? The throbbing character is very characteristic. They like the picture which I have shown, somebody who is pressing their head like this or tying a tight band or compression gives relief. That is typical of a vascular headache. Or the primary idiopathic vascular headache is what we call as migraine. Always exclude secondary vascular headaches to diagnose migraine. Because secondary vascular headaches we have already seen, like due to intracranial problems, meningitis, or venous thrombosis, arterial thrombosis, intracranial hemorrhage, they are also vascular headaches only. So identify the triggers of migraine. Having ruled out secondary causes of vascular headache, and you have come to a diagnosis that is migraine only. But once you have diagnosed migraine, the second step is to identify the causes for or the triggers of migraine. That's another step in management of headaches. Once you know it is a secondary vascular headache, identify the cause. Like, is it a cerebrovascular accident? Is it cerebral thrombosis? Is it meningitis? Is it benign intracranial hypertension, or is it ICSOL, intracranial space occupying lesion? So the approach is basically differentiate between secondary vascular headache and primary vascular headache. Once you know it's a serious headache, look for the cause and manage accordingly. Once you know that it is migraine, look for the triggers of it. That's a next step. So migraine is the commonest neurovascular headache. It's a primary benign disorder of the brain. There is dysfunction of an ion channel in the dorsal raphe nucleus that normally modulates sensory inputs and exerts neural influences on cranial vessels. That's why the vessels behave abnormally. The benign neural events, the neural events can be triggered by rhinitis. The rhinitis may be simply due to allergic rhinitis or due to viral infection. These people with migraine will get a severe headache following that. Or it may be eye strain. The eye strain may be due to refractive error or sometimes flashes of light or poor lighting, excessive lighting, anything, or abnormal smells sometimes. And these stimuli, neural events, can result in spasm initially. During the spasm, they may get ischemia, and the concerned territory might show its manifestations. Later on, dilatation of blood vessels results in headache. And that headache can further lead to further stimulation of the dorsal raphe nuclei. It's a vicious cycle. We need to break that vicious cycle. So migraine is therefore the commonest neurovascular headache. It's a primary disorder of brain with benign triggers often, but sometimes the triggers can be serious also. As I mentioned, there is a dysfunction of ion channel in the dorsal raphe nucleus. It can be severe and recurrent sometimes, but one should not rely on aura to make a diagnosis of migraine. Aura is rarely only seen, but if you get aura, it is a classical migraine. So having diagnosed migraine, remove the triggers. That is the most important management to manage a migraine. Do not go after the most modern treatments. Even prophylactic treatment is removing the triggers of migraine. Some serious headaches and risk factors, activators for vascular headache. Fever. A person with migraine proneness will get severe headache whenever there is a fever. Even otherwise, some fevers are associated with severe headache, as I mentioned before, like enteric fever, bacillary dysentery. Meningitis, obviously, it has it. Raised intracranial tension of any cause can have severe vascular headache. Post-lumbar puncture can trigger severe vascular headache, but everyone may not be having it. Hypoxia can have severe vascular headache. This is typically seen in mountain sickness. Recently, I had a patient with low hemoglobin, was climbing went to see a place in Wayanad. She was climbing rapidly, and halfway through, she got severe headache. It's like the mountain sickness, the hypoxia triggering vascular headache. Hypoglycemia can trigger vascular headache. This is typically seen in people who are on oral hypoglycemic agents or insulin. They wake up with severe headache in the morning, which indicates nocturnal hypoglycemia. Sometimes carbon dioxide retention can be a cause for a trigger for a vascular headache. This is seen in people with COPD or other reasons, hypoventilation syndromes. But always look for benign triggers and activators as risk factors for migraine. The migraine proneness is most often due to benign triggers. The commonest and correctable disorders are refractive error, eye strain due to other causes like poor lighting, excessive lighting, or flashes of lighting, or flickering light as in a TV screen, Very often it is a nasal block. As I mentioned before, most often it is allergic rhinitis. Atopic tendency has to be elicited very carefully. Postnasal drip may be the only clue. They may not even tell about the nasal block. So atopic tendency has to be elicited in everyone with migraine, and correcting that with a simple antihistamine is the only treatment that they need. Look for painful lesions in and around the eye and head, eyes, PNS, paranasal sinus, teeth, ear, including temporomandibular joint and mastoid process. Look for any of these benign triggers anywhere in the head. Cervical spondylosis may be a trigger in some individuals, especially when they come with migraine like headache in the occipital region. Anemia can be a trigger for severe migraine, especially iron deficiency anemia. Always be on the lookout for it. This is one thing which is often overlooked. People with anxiety and depression can be a trigger for migraine. Very often they get a milder form of migraine, and that is where you call it as a tension vascular headache. The main triggers for migraine or activators for migraine can be flashes of light, sunlight exposure in some, or watching TV or cinema, travel, fatigue, exercise, stress, maybe after relaxation from a stressful situation. Drugs like nitrates can be a cause for triggering migraine. Some people get severe migraine after certain brands of alcohol intake or preservatives in certain fast foods and junk foods. Perfumes may be a cause for triggering migraine. So ask about that also. Food and food additives can be a cause. Some people may be getting migraine after certain types of food or food additives like monosodium glutamate, Ajinomoto, typically referred to as Chinese restaurant syndrome. And some people get it after mayonnaise or cheese, which may be added to some of these junk foods. Emotional upset can be a cause. Some people get it during menstruation, lack of sleep. Hunger might be stimulating vascular headache. Weather changes can stimulate vascular headache in some individuals. So the causes are benign, and you need to find out the triggers and causes to control migraine attacks. Having diagnosed migraine, you can classify them into migraine without aura, which is common migraine. That is the commonest. This is the commonest. That is why it is called common migraine. Migraine with aura is classical migraine, but aura need not be there in most of them. Focal migraine is you get a classical throbbing headache confined to one area, maybe in the eye, maybe in the occipital region, maybe around the ear, but usually they will have some problem in that area. It's a throbbing type of headache, but it's confined to one area. Atypical migraine is clinically it looks like a vascular headache, but it has other features, which I will tell you later. Migraine equivalence is patient does not have headache, but there are neurological deficits which should be diagnosed, like as I mentioned before, basilar migraine or hemiplegic migraine, ophthalmoplegic migraine, sometimes abdominal migraine. They do not have the migraine at the time of development of these neurological events. Another commonly mentioned recurrent common headache is tension headache, which is classically defined as bilateral, tight, band-like discomfort around the head. They say that something is tied around the head, something as if some weight is kept on the head. And pain builds up slowly only and it fluctuates in intensity and persists for many days. It can be episodic or chronic, but most of these patients have underlying anxiety or depression, and that is a dominant trigger for, actually it is a milder form of vascular headache triggered by underlying anxiety and depression. And relaxation can improve the symptoms. It's better called as a mixed headache because there is anxiety. It is typically not a vascular headache, but it is a vascular headache in a minimal form, and there is anxiety as a trigger or depression as a trigger for it. In fact, the most headaches are mixed headaches only. Barring even the severe headaches are always mixed headaches. But if you look at even migraine, many patients may be having anxiety, anemia. They may have severe migraine, and the anxiety and eye strain and rhinitis all may be there as triggers. So one should look for multiple triggers for migraine in each patient. Anxiety and depression together as triggers for vascular headache, or painful lesions like iritis, sinusitis, trigeminal neuralgia as triggers for vascular headache. Sometimes the trigger may be cervical spondylosis with occipital headache. Eye problems like iritis may be the cause, or even refractive error, which we can call as ophthalmic migraine. Migraine can rarely precipitate seizure also, because during that ischemic phase, some patients with seizure proneness can go on to develop seizure. In fact, one patient with intractable seizures, which I had been managing, has been having recurrent migraine, and that was due to an underlying antiphospholipid antibody syndrome due to SLE, and the seizures were due to cerebral thrombosis, and she used to get a post-ictal headache also. The migraine was precipitated seizures too. So multiple problems can be occurring together, and migraine may be one of them. The vascular events like atypical vascular severe migraine can occur in AV malformation. Because it is a typical migraine, persistently unilateral migraine like headache, throbbing headache, but there may be an intracranial problem like AV malformation or a meningioma on that side. Rarely it could be a arterial thrombosis or embolism. In people who are migraine prone, they might come with severe headache on that side. Extremely rare recurrent headache is the cluster headache. I don't think we will ever see it. Once in a while only we will see cluster headache. Most of them are probably wrong diagnosis, because in my lifetime, I had seen only one patient with a cluster headache. So typical classical cluster headache. It is described as episodic short-lived periorbital pain for 4 to 8 weeks with a symptom-free interval for about a year. Sudden onset, non-pulsatile unilateral pain reaching maximal intensity in 5 minutes and remaining for 30 minutes to 2 hours. There may be associated lacrimation, retinostosis, nasal stuffiness on the affected side. So in fact, you are unlikely to come across a classical cluster headache. Now coming to clinical evaluation. I have talked about serious headaches and benign headaches and types of headache and the mechanisms of headache. Now let us see how do we proceed to evaluate a patient who comes with headache. While evaluating headaches, before you think of headache, first ask, is it a facial pain or not? The neuralgic pains has to be differentiated from vascular headache. The neuralgic pains are entirely different. They are tearing, sharp pains, unlike and pain touching the area will actually trigger the pain in neuralgic pains. Pressure will relieve the pain in vascular headaches. So one should know whether it is a facial pain or a vascular headache before you start evaluating. And then even if it is a vascular headache, look for serious headaches, serious triggers for vascular headaches. Then once the serious headaches and serious triggers are ruled out, you can diagnose migraine, which could be classical migraine or common migraine. And once you are diagnosed migraine, the next step is to look for triggers or the activators and risk factors for developing migraine. So all these should be done simultaneously. Always look for multiple causes, even if it is migraine. Even if it is a migraine, one should look for multiple trigger factors. So the clinical evaluation of headache has these 8 steps: the onset, duration, quality, severity, location, time course, associated symptoms, and what are the aggravating and relieving factors. I will take up one by one. If it is an abrupt onset, severe headache, the worst headache, it is of sudden onset, it is usually subarachnoid hemorrhage. But the abruptness may be missed out. That is why one still has to consider migraine. A wrong history of abrupt onset may be there in some severe headaches due to migraine. But if it is classically abrupt in a person who never had a headache, and there is neck stiffness, and there are features of raised ductal tension, it is going to be subarachnoid hemorrhage only. Insidious or minutes to hours, it is migraine. You can confidently say that, especially if there are no features of raised ductal tension and in a person who had migraine in the past. And if it is insidious headache, recent onset, and the persistent headache gradually worsening, and suspect raised ductal tension, especially if it is bifrontal headache. Unilateral, it is never a raised ductal tension. Aura and premonitory symptoms should make you think of migraine. Short duration of headache, recent onset, You have to think of all the causes. It could be migraine, first episode of migraine very rarely, but one should consider all the other causes rather than migraine first. Chronic long duration, always it is migraine. Long duration of headache, recurrent episodes, always think of migraine only first. The quality has to be assessed. Is it a throbbing headache or not? Throbbing character you can assess by, is the patient using pressure to relieve the headache? Or does the patient tie a tight band? That is throbbing headache. Or pressure relieving headache is a vascular headache. Or does the patient talk about a pulsating feeling? That's always a vascular headache. If it is preceded by aura, it is classical migraine. But if the patient says tight band-like sensation, think of a tension headache. But tension headache, I personally feel that there are milder forms of vascular headache where the trigger is anxiety or depression. Unilateral, tearing, sharp, paroxysmal, electric shock-like pain is neuralgias. They are not headaches at all. So this quality has to be looked at before you think of headaches. Sometimes people mistake trigeminal neuralgia for vascular headache. That's a point to keep in mind. The location has to be studied very carefully. Bifrontal headache, it is a common bifrontal vascular headache is a common migraine, but it can also be raised ventricular tension. I will talk about how to suspect raised ICT. Unilateral changing sides, always common migraine. Unilateral persistent can be a focal migraine, but look for a cause. If you get a unilateral focal migraine, like persistent pain in the eye, persistent throbbing pain in the occipital region, persistent throbbing pain in the ear region, look for a local cause there, like frontal, orbital, occipital, maxillary, temporal, all regions can be affected. You will get some local cause in that area. But it's never due to raised ventricular tension if it is unilateral headache. Unilateral headaches are never due to raised ventricular tension. The most severe headache can be even subarachnoid hemorrhage or migraine. But in fact, severity does not help us because the pain perception varies. Some patients exaggerate their pain and the most severe headache can still be migraine. It need not be subarachnoid hemorrhage. So don't go by severity alone to differentiate between the causes of headache. Even the most mild headache can be a severe condition also. So let us not go by the severity of headache to decide on the cause of headache. Persistently unilateral or focal, frontotemporal persistently unilateral can be due to refractive error or allergic rhinitis on that side. But the rhinitis can be due to viral infection also. Or there may be a ear, teeth, or PNS lesions on that side. It could be rarely due to intracranial space occupying lesion on that side, like AV malformation or meningioma occasionally. Glaucoma, iritis, retroorbital lesions can be a cause for persistent unilateral headache on that side. Occipital nuchal, the posterior area, it may be due to a posterior fossa lesion or lesions of the upper cervical spines. They make cervical spondylosis can also come with the occipital headaches. In fact, patients with raised ventricular tension very often start with the occipital headache because the intracranial space occupying lesions which are prone for early development of raised ventricular tension are the posterior, situated in the posterior fossa. Since posterior fossa sensations are also carried by the C1, C2, C3 region, dermatome, so the headache may be first referred to the occipital region. But it's not due to raised ventricular tension. Once raised ventricular tension develops, the headache will always be bifrontal. Look at the associated symptoms also. If there is allergic rhinitis, and if it is a vascular headache, it's almost always migraine triggered by allergic rhinitis. But as I mentioned, viral fever, viral infections can also have rhinitis. That can also trigger vascular headache. Postnasal drip may be the clue to that. Defective vision has to be elicited. One has to check the eye refractive error has to be ruled out. For as eye strain has to be elicited. Painful lesions anywhere in the head and scalp area. Fever, diarrhea, vomiting can suggest a systemic disease as the cause for headache. Visual symptoms like visual hallucinations or loss of vision, homonymous hemianopia, all can suggest some problem related to the headache. Vertigo can suggest posterior vertebrobasilar insufficiency or a ear problem triggering headache. Photophobia can occur in migraine, but it can also occur in meningitis. Mood changes are typically seen in migraine. Irritability, redness of eyes can suggest irritability is classically seen in migraine patients. Redness of eyes is seen in mostly iritis, glaucoma. Lacrimation also suggests eye problem as the cause of headache. The time course is important. After the development of headache, what has happened to it? Is it steadily worsening or is it waxing and waning? If it is steadily worsening, bifrontal diffuse, always think of a raised rectal tension. But if it is changing sides, completely relief in between, or sleep relieves the headache, it's never a raised rectal tension. So always find out the aggravating relieving factors and time course of the headache. That will also tell us about the etiology. So always study the person with a headache. Does the person have anxiety and depression, or any stressors in life, which could be traced to marital, financial, or social issues? Or has the patient got atopic tendency, allergic rhinitis, and the migraine can be due to any of these. Dietary habits are equally important. Always explore the possibility or the chances of having fetal folic acid and iron deficiency anemia, because anemia can be an important trigger for migraine headaches. Diet with the vitamin D deficiency can be a cause for tension type of vascular headache because the muscle spasm. Don't think it is always due to anxiety. The tension headache can also be due to vitamin D deficiency with hypocalcemia developing due to any mechanism. It's not just due to anxiety alone. Chopstick sign has to be looked for, therefore. Or ask about fast foods, alcohol, smoking habits, because smokers can have polycythemia. That could be the cause for headache. Fast foods can contain various substances which can trigger migraine. Alcohol can trigger migraine. The posture at work and sleep habits are important. Disturbed sleep may be the cause for headache, or the wrong postures may be the trigger for headache, or eye strain may be the cause of headache. So study the person with a headache even when it is due to migraine. But a new onset severe headache is an entirely different diagnostic possibility. If the person who never had a headache in the past now comes with a severe headache, always consider entirely different diagnostic possibilities, and the possibility of potentially serious cause is very high in them. Look for meningitis, look for its features, look for cerebral vein thrombosis, look for subarachnoid hemorrhage, epidural or subdural hematoma, glaucoma, purulent sinusitis. These are conditions one should not miss. Symptoms that suggest a serious underlying disorder are these. First, severe headache, worst ever headache, abrupt onset headache, but one has to be very careful in eliciting the abruptness. A patient might tell it is abrupt, but one has to give some examples. Is it like when you put on a light switch, the light comes all on a sudden? Is it like that? So that kind of abruptness means it is something different. Worsening over days or weeks, that suggests raising rectal tension. Abnormal neurological findings, fever or unexplained systemic signs, always suspect serious cause. Headache worse in the mornings and disturbed sleep, suspect raised rectal tension. Onset after 55. Headache induced by bending, lifting, cough might be indicating serious problems. So when to suspect serious headache? In short, I'm summing up the conditions where we should suspect serious headache. Recent onset and severe headache. The worst headache in life. Abrupt onset headache, but it should be classically truly abrupt. Occipital headache with the later on developing bifrontal headache. Persistent headache, worse in the morning, interferes with sleep, steadily increasing in severity. These are headaches where one should be careful of ruling out serious problems. So when to suspect? No benign activators also. It's not enough on physical or clinical evaluation. You find that there are no benign activators for a serious headache, severe headache, not serious, severe headache, which could be mistaken for serious causes. Headache on stooping, you should look for. Persistent giddiness, one should look for. Sometimes it may be subdural hematoma or extradural hematoma. bradycardia if it is there, neck stiffness if it is there, abnormal neurological signs, or presence of papilledema, very high blood pressure, you should suspect serious problems. So always look for these serious problems before you brand it as migraine headache. So in the physical examination, look at pulse rate, blood pressure, temperature. Pallor is important. Polycythemia is equally important because that could be a cause for the cerebral thrombus and headache. The hypoxia itself can trigger a migraine in polycythemic individuals, or they might also get cerebral thrombosis. So look for pallor as well as polycythemia. Look at peripheral pulses, including the dilated cranial vessels, like in temporal arteritis. The vasculitic disorders can be a cause for that. One has to look for refractive error, iritis, and glaucoma. Look for cervical spondylosis. The inverted supinator jerk is a very important sign. Look for Chvostek sign. It could be the cause or trigger for a vascular headache or a tension headache. Fundus, if you suspect raised ventricular tension. Examine the nose for nasal block. Ear for any ear pain or mastoid process tenderness, PNS tenderness. All these should be looked at. Look at the teeth also. Sometimes a painful teeth may be the cause for a focal severe headache. And temporomandibular arthritis may be the cause for a severe focal headache on that side. Cranial arteries, as I mentioned. And CNS, look at fundamental functions and localizing signs, manager signs, and psychological evaluation is equally important. When would you call it as an atypical vascular headache? Clinically, the patient has a vascular headache, but there are features of raised ventricular tension and CT scan is normal. This is a condition where you have to rule out chronic meningitis, especially tuberculous meningitis. Again, cerebral thrombosis is the one condition where you should consider whenever you get an atypical vascular headache. That means patient has diffuse bifrontal headache, raised ICT features are there, but CT scan is normal. Consider cerebral thrombosis. CNS vasculitis is another condition. SLE can present like that. And this is where you suspect benign intracranial hypertension also. But most patients with the benign intracranial hypertension are having undiagnosed cerebral thrombosis. If you get an atypical vascular headache, always do these investigations. Hemoglobin, PCV, for anemia, and thrombocytopenia and polycythemia. Total count differential count for abnormalities like polycythemia, very high ESR, thrombocytosis. MRI scan may be needed to look for intracranial problems or dilated ventricles or features of cerebral thrombosis. CSF study when you suspect meningitis, or MR venogram when you suspect cerebral vein thrombosis, and workup for vasculitis and prothrombotic states when you suspect cerebral thrombosis. We should know how to avoid or when to avoid CT scans. Do not get a CT scan when there are no features of a serious disorder. We have discussed all the features of a serious disorder. And if it is a typical vascular headache, long duration, recurrent episodes, if there are headache-free days in between, benign activators are there and the patient gets relief after correction of the trigger or activator, and the headache gets relieved after sleep. There's no point getting CT scan in such patients to rule out the serious causes. So while looking at for these scans, before we scan, let us scan with our senses. Look at the eyes, ears, nose, and sinus, teeth, cervical spine, and even a mind scan or a mental scan is more important than brain scan. Brain scan only as a last resort. So when will you do a CT scan? Recent onset severe headache, persistent and progressive headache. If there are features of raised ventricular tension, if there are lateralizing signs, if there are localizing signs, or if you get an atypical vascular headache, that is features of raised ICT, severe headache, you should get a CT scan. But is the headache due to raised ventricular tension or not? We have to decide. Unilateral headaches are never due to raised ventricular tension. Never suspect raised ventricular tension headache in unilateral headache. Episodic headache, alternating sites, always it is migraine. Do not suspect raised ventricular tension. If the sleep relieves headache, it is never raised ventricular tension. It is usually migraine. Persistent unilateral headache may require CT scan, rarely to look for intracranial problems like meningioma, AV malformation, but they are not raised ventricular tension. More importantly, in persistently unilateral headache, examine eye, ear, teeth, PNS, temporomandibular joint, and sometimes a PNS X-ray can help you. So when to consider raised ICT should be known to all. That's a very important point. I hope I already mentioned recent onset, steadily worsening, diffuse bifrontal headache, which does not get relieved after sleep. One should always consider raised intracranial tension. Coming to, so you have diagnosed migraine, and after ruling out all the serious cause of headache, how do we manage a patient with migraine? Reassurance is the most important, because the patient is almost always afraid of a serious disorder like a brain tumor. You need to tell that you don't have anything like that. That assertive reassurance is very important to them. And then we do everything possible to remove the trigger or avoid the activator and trigger. And the triggers can be a refractive error, nasal congestion, and the nasal congestion may be allergic rhinitis, or it may be anemia, especially iron deficiency anemia. Sometimes it is polycythemia. And if they may have depression or anxiety, manage that by appropriate measures. And antihistamines can relieve migraine headache in majority with the allergic rhinitis. Posture can be has to be adjusted in those who, especially IT professionals who get headache after working with laptops for long hours with an abnormal posture, having cervical spondylosis. They get relief after correcting the refractive error and adjusting the posture and lighting, including, and even the work schedule and sleep schedule. If you adjust, their headache may get relieved. And remove painful lesions, maybe teeth or pain, or manage all the painful conditions, including an impacted wax in the ear. Sometimes we had patients with the temporomandibular arthritis due to hyperuricemia. After that is managed, the headache on that side gets relieved. So prevention of attacks can, as I mentioned before, many of them can be controlled with atopic tendency, with allergic rhinitis, precipitating vascular headache can be controlled very easily with the levocetirizine. That is the only prophylactic required by those patients. And correct the cause of eye strain by correcting refractive error or lighting and posturing, posture adjustments, and patient education to avoid the triggers in diet and lifestyle, because avoid exposure to unwanted substances in diet like Ajinomoto containing mayonnaise, cheese. You need to identify which food could be responsible for the trigger. Regular sleep, regular meals, and exercise all can help in controlling migraine. Stress management plan can help in management of migraine sometimes, because some of them have migraine triggered by anxiety and depression also. Or regularity of habits is very important. Sticking to a schedule with a clock-like precision is very important in some of them. Avoid all the triggers for migraine. And for symptomatic treatment of migraine, once you get a severe attack of migraine, what will we do? You can use drugs like aspirin, acetaminophen, or NSAID can be used, but use them only as a last resort. Or a combination of paracetamol, flunarizine, and levocetirizine, which is not irritating the stomach, can be used. This is enough to control most of the common migraine, especially if they have allergic rhinitis too. Do not use ergot preparations and triptans, though they are effective in everyone, because they can have potential side effects, potentially harmful side effects. So one should not be using them regularly, but it may be selectively used in some individuals, but do not use it repetitively, especially those in people with hypertension, peripheral vascular disease, ischemic heart disease. They should not be prescribed triptans and ergot preparations. So analgesics like NSAID can be used, and it should be taken as soon as headache component of the attack is recognized. 500 to 650 milligram acetaminophen or naproxen or ibuprofen, but use it very carefully, sparingly, not always. And sometimes you may combine with antiemetic drugs to increase the gastric, the drugs that increase gastric motility to facilitate absorption of the primary drug. Avoid overuse of these drugs, and the intake has to be restricted to no more than 2 to 3 days per week. Do not allow them to continue it for long. Ergot derivatives are good, low cost, long experience with their use, but they have erratic kinetics, generalized vasoconstriction, and several adverse effects, and high risk for overuse is there. So better not to use it regularly, but in selected cases you may use. Opiates should not be used as a rule. They may mask the pain without suppressing the pathophysiologic mechanisms, and it may lead to cognitive impairment, and they may have a potential for addiction. So do not use opiates for controlling migraine headaches. Triptans can be used for acute attacks, but they have established efficacy, moderate side effects only, but they have well-established safety record also. But again, the higher cost and cardiovascular events and contraindication in hypertensive ischemic heart disease patients is a disadvantage. Again, do not use them always. Try to avoid use of triptans too. So there are mechanisms. Anyway, I will not be discussing the mechanisms of action of triptans. You can read them. There are 5 triptans, but the one which is usually used is sumatriptan. Most patients prefer the oral formulation only. The preventive therapy is decided by frequency, duration, and severity of acute attacks. And looking at, does the patient ask for a preventive therapy? That's one which decides whether you use it or not. Attacks are unresponsive to acute attacks, medications, and that cause substantial disability, then only you consider preventive therapy. It's not clear how preventive therapy works. Probably it modifies the pain-sensitive triggers. Anyway, if headaches occur 1 to 2 days per month, there is no need to give preventive therapy. 3 to 4 days per month also may be considered, but do not always essential. More frequent attacks, then only you should consider it. But do not use it upfront. More important is to correct all the trigger factors and lifestyle changes. That's more effective in as a preventive therapy rather than using prolonged use of these preventive therapies. The preventive therapy can be beta blocker, tricyclics, or flunarizine, or sometimes topiramate, anticonvulsants like topiramate, valproate, and gabapentin. All can be used, but do not use them upfront. Use them selectively in selected patients after doing everything that is possible to avoid triggers. And there are some newer trends in chronic migraine. Just I wanted to give it a passing comment only, but one should not go for it. It should not be an upfront management plan at all. These are not usually genuinely not required in 99.9% of the patients. Very rarely, some of them may require it as an experimental therapy. One should not go for it. One should not get fascinated by these newer therapies. Topiramate can be used in refractive migraine, and this botulinum toxin, anti-CGRP monoclonal antibodies, neurostimulation. These are the in things for migraine management. You will find a lot of literature on these things, but they are not in general required in majority of the patients. They're all experimental therapies only. So these are the mechanisms of using that particular newer therapies, because the sensitization of trigeminal afferents is critical for the development of chronic migraine. It is known that these people express significant increases in this particular receptor, that is transient receptor potential vanillopeptide type 1, TRP1, on nerve fibers, innervating the walls of these scalp arteries. These people have the increased expression of these TRP1 receptors. And these receptors promote excitation of the trigeminal-vascular pathway and mediate the release of calcitonin gene-related peptide, CGRP, and substance P. So botulinum toxin may be leading to a reduction of these receptors. That is a mechanism suggested. So anyway, I will not recommend these newer therapies for any of the migraine patients. I will share with you how did I manage my migraine. I had allergic rhinitis as a major trigger. In fact, it was diagnosed as sinusitis, and I was advised antral wash once, thinking that it was sinusitis. So if you have a patient who comes and says, I have a sinus headache, you can confidently say that it is migraine triggered by allergic rhinitis. Unless you have typical features of sinusitis, including inflammation, warmth, tenderness, redness, and severe tenderness on local touch. And there are fever also, like signs of inflammation, infection, then only think of sinusitis. Otherwise, a patient with a focal headache in the with the tenderness of the paranasal sinus, blocked nostrils. If there is allergic rhinitis, it is not a migraine at all. It is simple focal migraine triggered by allergic rhinitis. They need only antihistamines and reassurance. Never go for antral wash and treatment with antibiotics. This is what I had when I was diagnosed as sinusitis, and I could avoid all the triggers, and I never used even antihistamines, and my refractive error was corrected, and the eye strain was avoided, and I avoid all the triggers for migraine, which I identified the triggers as Ajinomoto, mayonnaise, and cheese. If I eat any of these, I get severe migraine. So by avoiding all these triggers, one can control the migraine. This is the best prophylaxis one should do for any patient with migraine. Identify the triggers. Sometimes it can be mild triggers like this, or it can be anemia, sometimes anxiety, depression, refractive error. Multiple triggers are there in each patient. Identify all the triggers, correct all of them, reassure them, and that's all what is needed for migraine management. Who will manage a patient with migraine? In fact, it is a general practitioner. It's a most ideal person because he or she can study all these issues in the community setting rather than sending them all to the hospital. General physician in the hospital setting. Ophthalmologist when refractive error or glaucoma or iritis as the cause for headache is identified. It can trigger a migraine also. ENT specialist when you have fungal or bacterial sinusitis. In fact, one of my patients severe focal migraine and the tenderness had a fungal mass in the maxillary sinus. Or when they have purulent sinusitis that or impacted earwax. These are the situations where an ENT specialist can be called in to manage a migraine headache. Dental help is important when there is a painful tooth. Neurosurgeon when you identify an intracranial space-occupying lesion, not to diagnose the cause of headache. Neurologist or a good internist for evaluation of intractable vascular headache, where you suspect some intractable multiple causes. You need better clinical evaluation. That's the stage at which you consult an internist or a neurologist to evaluate a headache. I will give some case histories before I conclude. This is a patient with recurrent vascular headache and poor scholastic performance. A 16-year-old boy. You can see he had nail biting too. In fact, he was getting antipsychotic medications for some time, but there was no relief. And then he was brought for a second opinion. You can see the flat nails and nail biting. This was pica due to iron deficiency. His hemoglobin was normal. That is why the anemia was, the iron deficiency was missed out. But his MCV was low. He had thrombocytosis and RDW was high. And that diagnosis once is made, if you correct that, the patient recovers from that. This one patient who had polycythemia causing headache. Polycythemia can cause headache because of the hypoxia itself, or the patient can develop a cerebral thrombosis. This patient again, polycythemia rubra vera, who had a headache due to multiple causes, including polycythemia and thrombocytosis. The patient had a cerebral thrombosis as well. This was a patient with giant cell arteritis or temporal arteritis. She had persistent severe headache on this side. You can see the tender dilated arteries, and ESR was very high. But don't think it is always present in temporal arteries. It's a systemic disorder. Sometimes only you find it in temporal arteries. I'll give a case history also. A 42-year-old housewife. She developed sudden onset headache 2 weeks back. In fact, it was noticed when she bent down to take something from the floor. That was time she noticed headache. It was bifrontal and excusing type. Very severe that she had to tie some cloth around her to get some relief. And then naturally one would diagnose vascular headache, migraine headache only. But the headache persisted for 2 weeks with varying degree of severity throughout day and night. She had vomiting also. At this stage, one should not think it as a migraine. That is a definite sign of raised endocrine tension. There was no visual blurring, fever, photophobia, seizures, or any other localizing symptoms or alteration of level of consciousness. But prior to the onset of headache, I could elicit a history that she had 8 to 10 episodes of loose stools with fever the previous day, 1 day prior to that. That was actually an acute colitis with bacillary dysentery. And she was overweight. Now you can postulate a few things. The dehydration is one trigger which could trigger a thrombotic state. And she was overweight. Overweight naturally can produce several procoagulant states. So anyway, we suspected cortical vein thrombosis, subarachnoid hemorrhage, and a typical migraine, intracranial space occupying lesion including. And these were the investigations we got. Hemoglobin was low, there was definite iron deficiency, MBC was low, RDW was high, and there was thrombocytosis, ESR was also high. But look at the SGOTPT, the liver enzymes were elevated. That shows liver disease, fatty liver. When you have liver involvement, that will lead to a prothrombotic state, like decreased protein CS. The natural anticoagulants are deficient in anyone with a subclinical or clinical liver disease. So that will also predispose to thrombosis. So this patient had dehydration due to diarrhea, vomiting, thrombocytosis due to iron deficiency, and hypercoagulable state due to protein CS deficiency. And obviously, such patients are usually butyl deficiency as well, adding to another factor that is hyperhomocystinemia. So these are the factors which lead to development of procoagulant state. And in fact, this patient had a normal CT scan, but we suspected cerebral thrombosis. We went ahead with a contrast CT, which showed a focal subarachnoid hemorrhage, but MR venogram only showed the cerebral sagittal sinus thrombosis. You can see the thrombosis in the straight sinus and sagittal sinus. It was a cerebral thrombosis triggered by multiple factors. This was another patient who had chronic headache with the features of raised ventricular tension and papilledema. CT scan was normal. We diagnosed benign intracranial hypertension. But since we suspected cerebral thrombosis, we went ahead with the venogram. It diagnosed sagittal sinus thrombosis. This is another patient who had an iritis and severe focal migraine on that side, persistent unilateral headache on that side. And that was actually due to tuberculous iritis, strongly positive mantle. That patient needs treatment with steroid and antihistamine, anti-tuberculous treatment, and local application of steroid from the ophthalmologist. This patient also had a sinusitis-like headache, chronic headache, vasculitic disorder. It was vaginous granulomatous. You can see the depressed nasal bridge in that patient. This patient came with severe headache and cardiac failure. You can see the polycythemia, the typical blue blotter type of appearance, cyanosis, a chronic smoker with the carbon dioxide retention and polycythemia. These were the causes for the headache in that patient. So you need to identify the cause in each patient rather than having a standard protocol for management in any patient with headache. I'll conclude with another case history. A 28-year-old male, sudden onset bifrontal headache and vomiting. He had some relief after IV fluids and some IV medication. We didn't know what it was. He received it from another place. Third day, he had abrupt onset vomiting followed by altered sensorium and we became unconscious. And the CT diagnosed it as meningioma with internal hemorrhage with a mass effect and a midline shift. And then the patient underwent a craniotomy and excision of the intracranial space occupying lesion with a diagnosis of meningioma. At surgery also, they suspected high-grade glioma. This was the lesion which was there and it was subjected to surgery. And histopathology showed infarct only. In fact, this patient was referred to me because there was no glioma after histopathological examination, but on evaluation, they found low protein S. That was at that stage, the patient was referred to me, but actually the patient had NASH with the protein CS deficiency and butyl folic acid deficiency, dehydration, leading to cerebral thrombosis. The point is, cerebral thrombosis can mimic anything, including migraine. It can mimic meningioma, it can mimic glioma, and it can mimic subarachnoid hemorrhage, and they will fool us. So one should be on the lookout for cerebral thrombosis when you have a typical vascular headache. So concluding, the take-home messages are, headache is one condition which should not be institutionalized. Actually, there's no point having headache clinics and all. That is only when they accept referred cases, it is possible. Otherwise, most headaches should be managed in the periphery by the general practitioner and in the hospital by the internal medicine or general medicine person. We need to sharpen the clinical skill to identify serious disorders and sharp clinical skill is also needed to diagnose migraine and to identify the triggers for migraine. And therefore, clinical skill is important in diagnosing and managing headaches. It's a person-centered approach is what is needed in management, diagnosing and managing migraine. Like any symptom, the causes are always multiple. Never be happy with one cause for migraine. The one patient with migraine may be having 3, 4, or 5 causes. And you get excellent results and satisfaction if you have proper approach to all the patients with the migraine. Thank you for the patient hearing. If you have any questions, we can take up and discuss that too.
Thank you, sir. Thank you, sir, for your excellent talk. It is very useful to all of us over here. Thank you so much. So if anyone has questions, please ask or put it in the chat box.
There is one question: how long prophylactic propranolol flunarizine to be continued? In fact, this is a very important question. The patients with migraine, I have been treating so many migraine patients. There's no patient who is on prolonged beta blocker or flunarizine. They will lead to unforeseen side effects. It's better not to put them on prolonged prophylaxis with any of them. If you carefully identify all the triggers and correct all the triggers, reassure them, most of them do not require prolonged prophylactic therapy. But acute attacks in these patients can be covered with a combination of paracetamol, flunarizine, and levocetirizine. That's what I have been doing. But it's not good to continue them for long. So the answer is better not to give them for long. Any other questions?
Have any questions?
Any other question? Direct questions?
Sir, I have a doubt.
Please.
Sir, when will we suspect abdominal migraine in children?
Very good. Very
and
good.
What are the triggers we have to suspect in them?
Okay, very good question. If you have a child coming with recurrent colicky abdominal pain, that's a situation where you start suspecting. But rule out all the other causes, including worm infestation and very rarely porphyria too. And these are not there. And the patient has recurrent abdominal pain, which promptly relieves after some time. But when the pain comes, it is severe. And you elicit a history of migraine headache in the family or in the child sometime in the past. That's the stage where you start suspecting abdominal migraine. Once you have suspected migraine, then triggers for migraine. Sometimes it may be the same items which we discussed, maybe the cause for the trigger. And sometimes cyproheptadine may be a good medicine in abdominal migraine in children. But one should rule out all these common problems. All other causes of intestinal colic has to be excluded.
Okay. Thank you, sir.
Thank you. Any other? Similar is the case with a patient coming with vertebrobasilar insufficiency or transient hemiplegia. If you know that the patient has no other cause from evaluation and the hemiplegia recovers like a transient ischemic attack, if you know that patient has no other predisposing causes and the migraine proneness is elicited, obviously you may have to get a CT scan or MRI scan to rule out serious disorders in such patients when they come with the neurological disorders. But once you have ruled out them, you can confidently diagnose it as migraine equivalent or Bickerstaff migraine or hemiplegic migraine can be diagnosed clinically, but you need to rule out the serious causes because the patient has a neurological disease.
Sir, one more question in chat box.
Please.
What about amitriptyline as prophylactic?
Very good. That is an important question. Amitriptyline as a prophylactic can be used only in a patient with a tension type of vascular headache or a patient with migraine and depression. That's an ideal patient where you use it. But again, the depression, if it is reactive depression, has to be addressed by addressing the causes for reactive depression rather than giving amitriptyline alone. So if you think a patient has depression and migraine together, amitriptyline is a very good prophylactic drug. But again, the primary treatment is addressing the causes for depression. So I'm telling that because patients with B12 deficiency can come with depression. Depression itself may be due to not necessarily be due to psychiatric problems, psychological problems. It can still be due to organic problems. Metoclopramide, it is used only to facilitate absorption of the medicine that you give. Like it has no prophylactic.
Then how to manage headache with viral fever, not subsided with paracetamol?
Okay, not subsiding with paracetamol. So if you have intractable headache in a patient with viral fever, that patient is somebody who has a hypersensitive vascular or a person with a migraine proneness. These are the patients who get severe headache when they get fever. There, the migraine proneness also has to be addressed. They usually have allergic rhinitis or refractive error or anemia. The other causes of triggers of migraine also has to be addressed along with that, rather than focusing only on the pain management. Once you give antihistamines or if the headache is very severe, as a desperate measure, you can use dexamethasone if there are no contraindication. In severe migraine, when you failed with everything and intractable headache, and if there are no contraindications, sometimes you can try dexamethasone to relieve the headache. But you have to still, after that, you have to look for the precipitating factors. But make sure there is no contraindication.
How to select preventive therapy for migraine, propranolol and flunarizine? How to select between them?
Propranolol can be used if you think that patient is a more anxious person without depression. Flunarizine can be given to anyone, but there is a risk of weight gain. That flunarizine can be given to anyone, but there is a risk of weight gain. So better not use any of these preventive therapies, provided you address all the trigger factors. But look for multiple trigger factors. That's the best policy.
Sir, hello, sir. Hello.
Hello, please.
Sir, what are the dietary modifications that we should introduce when a person having migraine or headache like that?
Very good question. Blindly you can tell a blanket dietary modifications, then tell the patient to identify the trigger for migraine in that patient. Mostly you can tell them to avoid all the junk foods and fast foods which contain artificial colors and flavors. Ajinomoto especially, mayonnaise and cheese especially, and yellow colored substances also. And fried food and also is a trigger sometimes, because if you have noticed, people with allergic tendency, they start sneezing whenever they take go near fried food. So that can trigger that migraine headache. So it's better to avoid fried food, junk food, fast food, all the artificial colors and flavors, especially mayonnaise, cheese, yellow colored food, and Ajinomoto. Then include plenty of vegetables, fresh fruits, and regular sleep habits. Correct all the other trigger factors like anemia, anxiety, depression. Once you correct all of them, it's not difficult to control a migraine, because as I have been controlling it all throughout my life. I have been having migraine since childhood. I don't have any migraine now. But still I get if I accidentally eat Ajinomoto containing food. By chance, sometimes it happens when we eat food from unknown places, we might get exposed to these things and I get severe migraine.
Sir,
please.
Sir, hello.
Please.
Sir, in a diabetic or hypertensive patient, so sometimes what should be is he developing any other lifestyle diseases, what should be the ideal food for such a person?
For a diabetic and a hypertensive person. Diabetic and hypertensive person, I think the diet we had discussed in another class. The diet should be balanced diet, diabetic and hypertensive especially, with plenty of vegetables, high fiber vegetables, very little carbohydrate, adequate fruits. That's the ideal diet, and avoiding the things which I mentioned, and go for a protein which is not fried, protein containing food, but avoid all the fast foods and junk foods. Perfumes, including perfumes, room fresheners, including maybe a cause for triggering migraine in some individuals.
One more doubt, sir.
Please.
We are doctors. We are treating patients in a busy setup. OP may come to around 350 to 400 in a primary health center in a busy setup. So I am asking about ourselves, sir. What should be the ideal snack that should be taken 2 hours, every 2 hours short snacks? What should be that? Usually we are getting like udnu vada, like
very good. That very relevant question. The udnu vada paripada things are not actually good for health. You may take fruits in between our snacks, if at all. Otherwise, whenever you eat some vegetables, fruits, and a good source of protein, along with the regular food. And if you're so tired, just take a 5 minutes break and lie down flat. You can become fresh and come back and continue working.
Thank you, sir. Thank you.
Okay, thank you.
So one more question.
Please.
So when we give flunarizine, do we need to give drug holidays, like 5 days a week?
As such, I am for using flunarizine whenever they get an acute attack. So I don't use it regularly in any patient because it leads to weight gain. So better to use it episodically rather than giving on a long-term basis. So you can give break whenever there is no headache. But some people may have difference of opinion because most people are using it indefinitely. I don't personally use flunarizine for a long period. I use it only when they get headache.
Any more questions?
There is one question. One patient taking propranolol 20 milligram OD daily for 2 months, but if forget to take tablet, migraine precipitate with the trigger. No, there's no point increasing it. It is as such, it is only a prophylactic drug. We don't have to increase the dose. Identify the trigger. Again, propranolol should not be used for long in patients with migraine. It's better to find out the triggers and avoiding the triggers.
Hello, sir.
Hello. Please.
Sir, നമ്മുടെ OP-യിൽ കുറെ പേഷ്യൻസ് റിക്കറന്റ് എപ്പിസോഡ്സ് ഓഫ് വെർട്ടേഗോ ആയിട്ട് വരുന്നുണ്ട്. അപ്പൊ പലപ്പോഴും നമുക്ക് ഇതൊരു BPPV ആണോ ഒരു വെസ്റ്റിബുലാർ മൈഗ്രെയിൻ ആണോ എന്ന് കൺഫ്യൂഷൻ ഉണ്ടാവും. അതിനെങ്ങനെ നമ്മൾ ഡിഫറൻഷിയേറ്റ് ചെയ്യും?
I'll tell you. My recurrent episodes of vertigo is multifactorial always. Identify whether that patient has got allergic rhinitis. That may be with the eustachian catarrh may be one of the factors. Some patients many of them have cervical spondylosis. Many of them have coexisting butyl folic acid deficiency. All this together and a migraine proneness. These multiple factors are responsible for the recurrent vertigo and so-called benign paroxysmal positional vertigo. It's only benign BPPV only means it is benign, it is paroxysmal, there is vertigo. It does not give you the cause. It's always due to multiple causes. The combination of problems you will be able to find out are many of them have cervical spondylosis. Many of them have coexisting allergic rhinitis. Many of them have butyl folic acid deficiency. Some of them have other problems as well. So we need to find out, some of them have already existing damage to the vestibular apparatus. So all these may be coexisting. And in addition, there may be a migraine proneness also. So address all of them, the triggers, and correct all the deficiencies, tell them about proper posture adjustments, and give symptomatic treatment as and when, and give neck exercise also. Most of them can be controlled gradually. And avoid use of pillows because most of them have cervical spondylosis. I hope it is clear. And betel deficiency is very important. Many of them have coexisting betel folic acid deficiency. Betel deficiency is one of the most important causes for these postural imbalances, and it is always missed. Is it clear, Haris?
സാറ് ഇപ്പൊ പലപ്പോഴും അങ്ങനെ ഒരു പേഷ്യന്റിനെ കാണുമ്പോൾ നമുക്ക് ലാബിനെന്തെങ്കിലും സെഡേറ്റീവ്സ് എഴുതാനുള്ള ഒരു ടെൻഡൻസി ഉണ്ടാകുന്നുണ്ട്. പക്ഷേ
that is symptomatic treatment only. Like when a patient comes with fever, you will give paracetamol. You may give labyrinthine sedatives. Temporarily, there will be improvement, but that's not the final word. You may give it, but start correcting all the trigger factors. The triggers can be any of these or multiple triggers are there.
അത് വളരെ കോമൺ ആയിട്ട് കാണുന്ന ഒരു സിനാരിയോ ആണ്.
I know that is very common, but most of them have multiple causes, and one of them is cervical spondylosis, another is allergic rhinitis, another is betel folic acid deficiency. Posture adjust cheyanam. You have to tell them to do some neck exercise depending on their abilities, and then give betel folic acid, even vitamin D. Adequate hydration is important, proper diet is important, weight reduction is important. So if you do all of them together, they will get better.
So the cervical spondylosis എങ്ങനെ വെർട്ടിഗോ
it is not because when you have cervical spondylosis, there is partial compression of the vertebral arteries. There will be some ischemia to the vestibular apparatus, partly at least. So that can trigger, that it can contribute to it. It's not that it is the only cause. People say it is not cervical spondylosis that is causing benign paroxysmal postural vertigo. It's a problem in the middle ear. But problem in the middle ear may be also due to betel folic acid deficiency. The auditory apparatus, vestibular apparatus, they may be dysfunctional due to the betel folic acid deficiency or some already existing damage. Or it may be allergic rhinitis with the dysfunction of the vestibular apparatus. Eustachian catarrh can produce it. So identify the triggers rather than giving labyrinthine sedatives alone. Exercise definitely helps. And supplementing all the vitamins definitely helps.
Thank you, sir. Thank you.
Thank you.
So one more question.
Ergotamine
containing tablet is commonly in use. Can we prescribe those continuously or as SOS?
Do it only as SOS only, but after ruling out all the contraindications. The contraindications are peripheral vascular disease, hypertension, ischemic heart disease. Never use in those with peripheral vascular disease, hypertension and ischemic heart disease. And younger individuals only use it. If there are no contraindications, you can use it SOS. Never use it continuously.
Sir, will prolonged use of mask trigger migraine?
It can trigger migraine in those who are prone for it because mask itself is a cause for allergic rhinitis. Sometimes it is a cause for hypoxia even and stress, and you may get migraine attacks in some people at least.
Then exercise is a trigger factor, should stop it.
Exercise is usually not a trigger factor. Exercise without adequate preparations like adequate water intake and having other problems like anemia, such underlying problems may be the cause for exercise-induced migraine. There is no exercise by itself is not a cause for migraine. Sometimes they come with the exercise. As I mentioned, just now only, I think I had mentioned about a patient. That patient developed severe intractable migraine while the patient was climbing a hill. But she had anemia. Climbing hill, that is like a hypoxia was the trigger there. So you rule out the trigger and then exercise will not be a problem. Hypoxia can trigger migraine. So exercise, if it triggers migraine, there are other causes. Any other?
Any
I
more
hope-
questions?
I hope we have finished all the questions also. We will wind up. Thank you all for sitting for 1.5 hours listening to me. Hope it was useful to all of you. If it is useful, we can have future sessions on similar topics. Thank you all. I can see Dr. Madhav Das, my classmate. Anybody? Any other point to be? Hope we can conclude.
Yes, sir.
Thank you. Shall we wind up?
Okay, sir.
Thank
Good
you.
evening, all. We had a very enlightening talk on the practical approach to headache, and I hope each of us could widen our knowledge on the topic and also very well use these practical tips in our daily practice. And at this point, I extend my gratitude to our Dr. P.K. Shashidharan, our beloved teacher, for this excellent talk. On behalf of Department of Family Medicine, I also thank each and everyone who have attended the webinar and participated in the discussion. And we hope that we'll be back with newer topics soon. Thank you all.
Thank you. Good night. Thank you.